Hello, my name is Crystal Jackson, and I am the Director of Clinical Education and Professional Development for Vanderbilt University Medical Center Adult Ambulatory Clinics in Nashville, Tennessee. And we are going to talk to you about the standardization of a competency based orientation checklist.
My name is Jenna Beamer. I am a nursing education specialist at Vanderbilt, and I helped do this work in our ambulatory areas. By the end of this presentation, the learner will be able to describe a structured approach in creating standardized competency-based orientation checklists, recognize how to ensure orientation checklist is comprehensive for onboarding your new staff, establish a process of how to get started and remain organized, and understand how to get endorsement from key stakeholders. So, do you have initial competencies that are all over the place? If you are like us, the answer is yes. We had we've been slowly standardizing our things in our outpatient areas to make sure that they're more in line to how we are running things in the hospital. And of course, we want to keep up with evidence-based practice and make sure that everything is as good as possible. So we embarked on this pretty huge endeavor last year, and we are really excited to share what we did and the steps we took to get this project on the ground.
So, we're going to talk about our initial competency approach. We took an approach to start off by looking at our initial competencies. So, step one, we had new leadership that joined us as a new CNO of our adult ambulatory clinics, as well as a new director of education and professional development. And so we established a collaborative partnership to really evaluate our orientation and onboarding process. We took a look at our initial competency checklist, and we wanted to ensure that they were competency based checklists. So we did that first. Step two, we identified current competencies listed on our orientation checklist. So we had a meeting where we sat down for several hours and we brought all of the different pieces from different areas, different specialties, different subspecialties together and really honed into the current competencies that were listed. We found a lot of duplication. We found a lot of efforts that we really wanted to narrow down and make it more standardized across the board. So, what we did was we spent 2 8-hour days of just really going through and evaluating the current competencies listed, taking out the old things that we did not feel were appropriate to be added on there, and then adjusting it accordingly. And lastly, we had this idea of creating a core competencies just for ambulatory. So we cleaned up our checklist. We identified core competencies that would be standardized for all ambulatory new hires across the board. And so once we did that, we recognized that if a lot of our ambulatory core competencies could work across the board, then the next step would be to create our unit or area specific competencies, which would decrease significantly because a lot of those crossed over when we did our cleanup.
So let's talk a little bit about the core competencies. So the core competencies involved our adult ambulatory educators. And so those educators represent a host of areas such as surgery, ortho, GI, primary care, eye clinic, neuro, asthma and allergy, and a host of others. So we brought all of those individuals together. And again, I described it as 2 8-hour days where we knew our intention was to focus on our current checklist and try to get those current checklists to a point to where it made sense to create a core competency. On those 2 hour days, we had things, for example, in our ortho clinic, we talked about quality initiatives, and then we compared it to our asthma and allergy clinic, who also talked about quality initiatives, but they weren't speaking the same language. And since they weren't speaking the same language, we wanted to make sure that we came to a point that all of it was consistent for core competency. And so we came up with the result of understand the roles of quality initiatives. We identified that as something that was on all of our checklists, and now we can tap that into our core checklist as a general statement. The why was because we wanted to ensure that we were following accreditations and standards, and also the task that we identified as a core competency. For example, if we identified that all of our clinics on our core competency were to understand proper technique to IM injections according to policy per the clinic standard, that covered the accreditations and standard. We also had experience in sitting in on a regulatory survey where the surveyor saw several different clinic areas that were core competencies. And once they saw that the core competencies were consistent, the regulatory body moved on from that topic. So that is really the who, the how, and the why of our core competencies and how we made this very successful.
So we looked at our initial competencies and we wanted to ensure that we were following the Donna Wright competencies. We do base all of our initial competencies as well as our annual competencies off of Donna Wright's theories. So the 4 buckets that you see here really relate to Donna Wright practices, the core job functions. We identified what we felt were the core job functions for all of adult ambulatory. What did they need to know before they're out of orientation? So we recognize that there are so many different specialties in ambulatory as well as subspecialties, but we really wanted to ask the question, what are the key job functions that these individuals need to know as a new hire here at our adult ambulatory clinics before they are released from orientation? Next, we looked at the frequently used job functions and the accountability. So we recognize what are their job functions and how do we hold these individuals accountable for what they're doing day to day. So we looked at those pieces and we just pull those out to really work on that and to function. We looked at high risk job functions. So those high risk areas that we know really do need some type of competency as part of their initial competency, we did address that right away. So if we looked at an oncology area and the subspecialty, we wanted to make sure that as part of the initial competency, it was identified as well as outlined on their checklist. Then we looked at the intended essence of their job. What is the essence of these individuals' job as a new hire here in our adult ambulatory clinics, and to ensure that we capture all of that in their orientation initially on their checklist. So we took a moment to look at our clinical orientation, our hands-on clinical orientation, as well as our learning management system. And what we did was we identified all of those skills that were captured in clinical orientation. And then we also looked at all of those items that were from our learning management system. And we tried to make sure that we did not duplicate that work in our initial competency checklist. So the way that we deciphered that is we looked at all of the regulatory content that we know that we need to offer in a hospital orientation, as well as any content that we offer in our learning management system, such as medication safety and administration modules and safe patient handling. And we kept it in one area. Then from there, we looked at our initial competency checklist for the unit-based areas, and we made sure that we did not duplicate any of those skills. So for example, our electronic health record, we made sure that they already have a class for that is totally separate from clinical orientation. And what we did was we just captured that as ensure that you capture that skill during orientation. Another skill that was on our checklist is an example for ambulatory is the intake. We wanted to make sure that everyone understood intake And lastly, for medication administration, we identified that specific skill and task as we want to see you actually give medication. And we outline all of those pieces in that competency checklist.